Quantifying diastolic dysfunction by echocardiography is essential for identifying heart failure with preserved ejection fraction. The clinical standard is based on 2016 ASC EACVI guidelines, though emerging research in 2025-26 emphasizes the integration of left atrial strain for higher sensitivity. In patients with a normal left ventricular ejection fraction, that is more than or equal to 50%, and no known heart disease, the presence of diastolic dysfunction is determined by four primary variables: average E by E prime ratio more than 14, septal E prime velocity less than 7 cm per second, or lateral E prime velocity less than 10 cm per second. Peak tricuspid regurgitation velocity more than 2.8 meter per second. That will correspond to a TR gradient of nearly 32 millimeters of mercury and around above 40 millimeters of mercury systolic pressure in the pulmonary artery. Left atrial volume index more than 34 ml per meter square, indicating that the left atrium is dilated. Less than 2 positive criteria will be interpreted as normal. Exactly 2 positive criteria is indeterminate, and more than 2 positive criteria will be taken as diastolic dysfunction. Once left ventricular diastolic dysfunction is confirmed, or if the patient has a reduced left ventricular ejection fraction or structural heart disease like left ventricular hypertrophy, the focus shifts to grading the severity and estimating left ventricular filling pressures. Grade 1 is impaired relaxation. The physiology is that left ventricle takes longer to relax, but filling pressures remain normal. Mitral inflow E by A ratio is less than or equal to 0.8 and E velocity less than or equal to 50 cm per second. Clinically, these patients are typically asymptomatic at rest but may have dyspnea on exertion. Grade 2 is pseudonormal pattern, in which the physiology is moderate diastolic dysfunction where increased left atrial pressure pushes blood into the left ventricle, making the inflow pattern look superficially normal. Mitral inflow E by A is 0.8 to 2.0. To verify or confirm grade 2, you must meet at least 2 of the 3 follow-up criteria. 1. Average E by E prime more than 14. 2. Left atrial volume index more than 34 ml per meter squared. 3. TR velocity more than 2.8 meter per second. Grade 3 is restrictive filling pattern. The physiology is severe left ventricular diastolic dysfunction with high left atrial pressures and a stiff, non-compliant left ventricle. Mitral inflow shows E by A more than 2.0. Clinically, it is highly suggestive of advanced heart failure and poor prognosis. While the 2016 criteria are specific, they can be insensitive. Contemporary practice now often includes left atrial reservoir strain. A value less than 18 to 20% is highly predictive of elevated filling pressures even when standard Doppler measurements are borderline. A clinical score H2FPEF, that is heavy hypertensive, atrial fibrillation, pulmonary hypertension, elderly, filling pressure, used alongside echo to rule in HFPEF. The H2FPEF score can be used to predict prognosis in patients having heart failure with preserved ejection fraction. Higher scores are associated with higher all-cause mortality and rehospitalization rates. Diastolic stress test. If resting echo is indeterminate but the patient has exertional dyspnea, an exercise echo is performed to see if E by E prime increases or TR velocity rises significantly. Here are some common pitfalls and limitations. In atrial fibrillation, E by A ratio cannot be used, obviously, as there is no A wave. Assessment relies on TR velocity, E by E prime, and the acceleration rate of the E wave. Mitral annular calcification, which is becoming increasingly prevalent in the elderly, especially those with chronic renal failure, can falsely lower E prime velocities, leading to an overestimation of E by E prime ratio. Moderate to severe mitral regurgitation or mitral stenosis renders standard E by E prime and E by A criteria unreliable.